Bismillahirrahmanirrahim. Today I'm going to talk about Fistula-In-Ano with you. Fistula-In-Ano, by definition, a fistula-in-ano or an anal fistula is a chronic abnormal communication, usually lined to some degree by granulation tissue, which runs outwards from the anorectal lumen, that is the internal opening, to an external opening on the skin of the perineum or buttock, or rarely in women into the vagina. So this is the definition of fistula-in-ano or anal fistula. This tract is usually lined by a granulation tissue. Here you can see this is fistula, and this is internal opening. Over here you can see the duration over there. This is the tract of, and this is the skin of the perineal area, and this is buttock. So this is the tract indicating this is fistula-in-ano. Here you can see external opening in the immediate vicinity of the anal orifice. This is external opening, and it's again a case of fistula-in-ano. As far as the epidemiology is concerned, anal fistula they are more common in male than females. This is for unknown reason, that this non-specific variety of anal fistula, they are more common in male than female. The overall incidence is about 9 cases per 100,000 population per year. The common age group for this condition, fistula-in-ano, is in the 3rd decade, 4th decade, and 5th decade of life. Regarding the etiology of the fistula-in-ano is concerned, majority of the fistula, they are termed non-specific. They are idiopathic. They are basically cryptoglandular in origin, and intersphincteric gland infection is basically deemed central to the concept of this idiopathic or primary fistula. Anal fistula may be found in association with a number of diseases, and in those cases we say that this is secondary fistula-in-ano. The above variety was a primary fistula-in-ano, which is also called idiopathic. Now the second type is also called secondary fistula-in-ano, which is associated with so many diseases. There are a number of diseases which are underlying in this condition, like Crohn's disease, tuberculosis of that area, rectal duplication, lymphogranuloma venereum, actinomycosis. Foreign body leads to secondary fistula-in-ano, and sometimes rectal tumors, anal canal tumors, they present with a fistula-in-ano which is of secondary variety. Here you can see now the development of fistula-in-ano. You must remember the basic underlying cause is anal gland infection. Now this is the intersphincteric plane where the anal glands they lie. So you can see here the anal gland infection basically which starts. Here you can see this infection in this plane is so a fistula-in-ano complicates about 30 to 50% of perineal abscess. That means in cases of perineal abscesses, which are number of varieties, about 30 to 50% they lead to fistula-in-ano formation, and these perineal abscess in majority of the cases they are due to anal gland infection. So here you can see, here the infection started in the anal gland. It is an infection over here, abscess formation, and that can lead to a fistulous tract here in the lumen and then outside in this plane. You can see that this is fistulous tract. Here again, this anorectal abscess that can lead to different direction, upwards, downwards in the perineal area, and then even in the ischiorectal fossa, and that leads to number of tracts. Here you can see a complex fistula, Fistula-In-Ano with number of tracts. Here you can see. So what is basically important, the development of Fistula-In-Ano, you must remember, it is the anal gland infection. That's why, because it's a tubular gland, it's duct open at the level of dentate line in crypts of liver cone in the anal canal, and that's why internal opening is usually at that site. So we know classification of Fistula-In-Ano. We will talk about that. There are a number of ways in which we classify Fistula-In-Ano. One way is that we classify fistula may be primary or fistula may be secondary, as I told you in the earlier slide. Primary, which is more common, idiopathic, cryptoglandular in origin, and secondary fistula when it is due to some underlying disease. There are so many diseases which are associated with fistula formation, and we then say this is secondary fistula. Another variety, which is based on the level of internal opening related to the anal sphincter, is Fistula-In-Ano may be of low variety, it may be of high variety. Now what is basically the difference between the two? If the internal opening begins above the anal canal, anal sphincters, above the dentate line, then the fistula is usually described as a high variety. It's not usually common as compared to low variety. Another way to classify Fistula-In-Ano is by Parkes classification. Another system, we classify Fistula-In-Ano. So this is the most widespread and useful classification of anal fistula, that is Parkes classification. This is based on the centrality of intersphincteric anal gland sepsis. That means the internal, which is I told you, this is intersphincteric anal gland sepsis, which results in a primary tract whose relation to the external sphincter defines the type of fistula and which influences the management. So this is very important classification, though the most widespread useful classification, Parkes classification. Okay, so it is again starts in the anal gland sepsis and takes different pathways. So now there are a number of varieties when we say Parkes classification. You can see in this photograph diagram the 4 types of Fistula-In-Ano according to Parkes classification. That is intersphincteric fistula, transsphincteric fistula, suprasphincteric fistula, and extrasphincteric fistula. Here you can see the different tracts. This is intersphincteric fistula. This tract is intersphincteric, between the two sphincters. This tract, the external opening is in the perineal area and the internal opening is here. This is intersphincteric fistula. Here you can see this is transsphincteric fistula. Outside both the sphincters, the transsphincteric fistula, this tract. Then suprasphincteric, here is the suprasphincteric tract. Here you can see suprasphincteric, again obviously the cause in the anal gland sepsis in the intersphincteric plane, but the tract is going above the external sphincter, and again at the opening, internal opening, usually at the dentate line. So in all these three varieties, you can see the internal opening is at the level of dentate line, that the duct, where the duct of the anal gland opens into the crypts of lubricant. This is extrasphincteric fistula. This is the extrasphincteric fistula tract. You can see above the outside the both sphincters and above into the levator ani muscle. So this is how we define four types of according to Parkes classification. Now if we move on to individual varieties, intersphincteric fistula, which makes about 45% of the cases of primary Fistula-In-Ano. It do not cross the external sphincter, and for the most medial subcutaneous fibers running below the distal border of the internal sphincter. So intersphincteric fistula do not cross the external sphincter. Most commonly they run directly from the internal to the external opening across the distal intersphincteric. Here you can see the distal this is internal sphincter. This is the tract of the, so this is the most common variety according to the Parkes classification. 5% of the cases they are intersphincteric. They, in the terms of low and high, simply is a low lying fistula. Second variety, which is transsphincteric Fistula-In-Ano, this variety makes about 40% of the cases. So the transsphincteric fistulae, 40% cases have a primary tract that crosses both internal and external sphincter. Here you can see this is the tract. This is external sphincter and this is internal sphincter. So this tract is crossing both the sphincters. Here you can see that. So both internal and external sphincter, they are crossed by the primary tract. The external sphincter at a variable level, it crosses at a variable level as far as the external sphincter is concerned, and which then passes through the ischiorectal fossa to reach the skin of the buttock. Here you can see this is ischiorectal fossa here, and it comes to the skin of the buttock. Here you can see that. Circumferential spread of sepsis may occur in the intersphincteric plane and pararectal plane as well as in the ischiorectal plane. So this is how the primary tract may have secondary tracts arising from it, which often reach the roof of the ischiorectal fossa, which may rarely pass through the levator to reach the pelvis, and which may spread circumferentially in a horseshoe shape. So this was a description of transsphincteric Fistula-In-Ano. Now the third variety, according to the Parkes classification, which is suprasphincteric fistula. This is suprasphincteric fistula tract. Here you can see that. Suprasphincteric fistulae are very rare, very uncommon, are thought by some to be iatrogenic, and are difficult to distinguish from high-level transsphincter tracts, for which fortunately management strategies are similar. So now the fourth variety of, according to the Parkes classification, is extrasphincteric fistulae. Extrasphincteric fistulae run without specific relation to the sphincters and usually result from pelvic disease or trauma. So we are talking about this fistula tract. This is extrasphincteric fistula tract. You can see that, and this may result from pelvic disease or trauma, and there is no definite relation to the sphincter. Now if we come to the clinical features, how these fistulae they present. They usually present with intermittent discharge that may be purulent or blurry. So patient complain, usually they complain of intermittent purulent discharge which may be blurry, or maybe it is associated with pain which increases when there is a temporary and until temporary relief occurs when pus discharges. So when the external opening is sometimes blocked, that is dried, so the pus pends up in the tract, and this results in severe pain sometimes, and the relief only occurs when the pus discharges from the external opening. Another clinical feature of Fistula-In-Ano is pruritus in eye, pruritus around the perineal, around the anal opening in the perineal area, as there is a discharge from that, and that results in pruritus. There is always history of maybe there is a history of previous episode of anorectal sepsis. Maybe a patient presented with may give history of anorectal abscess. Sometimes the passage of flatus or feces through the external opening is suggestive of a rectal rather than an anal internal opening. So if the patient complains that flatus or feces come through the external opening, so that means the internal opening is not in the anal canal, it is usually in the rectum. So this suggests a high internal opening in the rectum. Now, how we do the clinical assessment or examination in these cases? A full medical history. History is very important in these cases. A full medical history including obstetric history in cases of female, gastrointestinal history, recurrent GIT, and surgical, and history about the continence regarding the anal opening are necessary. So we have to take a detailed history in these patients. Before any surgical procedure is carried out, an examination under anesthesia should be performed. EUA. EUA means examination under anesthesia. And full EUA, basically a full examination or inspection of the perineum, but this is done under anesthesia. We can examine these patients without anesthesia, and usually on that we can see where is the external opening lying in relation to the anal verge, and we sometimes describe on a scale of clock at which point the external opening is lying. So a full examination is also mandatory under anesthesia, and this should be followed by a digital rectal examination and proctosigmoidoscopy. And digital rectal examination, we see when we introduce the finger within the lumen of the anal canal, we palpate the area of induration, we can palpate the fibrous tract, we can palpate the internal opening, and that these may be felt on digital rectal examination. Proctosigmoidoscopy is mandatory in these patients because it's not only for the diagnosis or to locate the internal opening, but what is important, we have to exclude other underlying diseases also. That's why no surgery should be done without proctosigmoidoscopic examination. So that must be done to exclude any underlying disease. Now, what are the different points we notice when we do examination under anesthesia? When we do examination under anesthesia for fistula-in-ano, we basically see what is the site of the internal opening, where is the site of external opening, what is the course of primary tract, presence of secondary extensions in relation to the primary tract of the fistula-in-ano. Then also while doing examination, especially when do digital rectal examination, we also assess the strength of the sphincter. Anal sphincter strength is also assessed. And presence of other conditions complicating the fistula, they are also diagnosed when we do examination of anesthesia. That's why we have to exclude these conditions which sometimes may be underlying to the fistula, the formation. Good sir rule. Good sir rule is used to indicate the likely position of the internal opening according to the position of the external opening. This is helpful but not always infallible. So what is good sir rule? Usually this is asked, what is good sir rule? Basically good sir rule helps us regarding when we see the external opening, and then we can assess where could be the internal opening. This is also helpful that it tells information, gives information in the horizontal plane. Now what is good sir rule? According to this rule, an imaginary line, a horizontal imaginary line which bisects the anal opening into an interior half and a posterior half. This line passes through when we 3 o'clock to 9 o'clock position and horizontal line. Now according to this rule, if the external opening is anterior to this imaginary line, horizontal imaginary line, the fistulous tract usually runs directly into the anal canal. Here you can see this is the imaginary line. Here this is the external opening in the anterior to this line, and the internal opening is in the anal canal, and the tract is direct one. Here this is the direct one. But if the external opening is posterior to this line, so you can see here or here, the fistulous tract curves to the posterior midline. That means fistula tract may be curved one, and the internal opening is usually in the posterior midline of the anal canal. So these tracts, they are curved when the external opening is lying posterior to this midline. But there is another part of the good sir rule. If the external opening lying anterior to this horizontal line, but it is about 5 cm from the anal verge, again there is a chance the fistula tract may be curved one and going into the posterior midline. This is again a part of the good sir rule. So now we come to the what are the investigation which we do for fistula-in-ano. There are a number of investigations which may be helpful for imaging our fistulous tract. But in the beginning I tell you, MRI nowadays it is the gold standard investigation for fistula-in-ano. Remember, if somebody asks what is the important investigation relation to for fistula-in-ano, it is the MRI, which is the gold standard investigation for fistula-in-ano. What are the investigation which we do? Maybe it's a fistulography, endo-anal ultrasonography, MRI. These are the different investigation, as I told, but it is the MRI which is the gold standard investigation imaging for fistula-in-ano. Here we can see a fistulogram. A fistulogram is one in which a contrast injected from the external opening by putting a very small fine catheter. It reveals primary and secondary tract. It is useful if an extrasphincteric fistula is suspected. Here you can see this is a fistulogram. Contrast is injected from the external opening and delineates the tracts, even in the this is the anal canal and rectum. Here you can see that. This is a photograph showing endo-anal ultrasonic. This is another very important investigation, imaging for Fistula-In-Ano. Endo-anal probe is used, and this gives a lot of information because it gives us the information of all the layers of the anal canal. So endo-anal ultrasonography is very helpful to see the normal anatomy of the anal canal, and in case of Fistula-In-Ano. Here you can see this is a tract. This is external sphincter. This is internal sphincter. This is external. Here is the tract. You can see there. So it is very helpful when there is a fistulous tract. They are very complex. This is another endo-anal ultrasound, endoluminal ultrasonography. Here you can see this is a horseshoe fistula, horseshoe tract. This is horseshoe fistulous tract. You can see this endo-anal ultrasonography. This is MRI. As I told you, this is considered gold standard imaging for Fistula-In-Ano. Here, this is one MRI where you can see a high variety supra-sphincteric fistula, high variety. This here you can see that. This is again MRI. This is a horseshoe fistula. This is the tract. This is all MRI, magnetic resonance imaging for Fistula-In-Ano. Now, if you want to treat the Fistula-In-Ano, the treatment of Fistula-In-Ano, I tell you, it is surgical. It is surgical. This is a very notorious condition. There is a very false impression in the people that this is one condition where recurrence occurs. So, what is important? There are a number of procedures they are performed for the treatment of Fistula-In-Ano. But what is important? It is the surgeon who is important, who can do that Fistula-In-Ano properly. So, at the top, I would like to say, treatment of the Fistula-In-Ano, obviously we have to resort to some surgical procedure. But more than that, what is important, that it should be done by an expert surgeon who is acquainted with these procedures. So the number of procedures which are done, one is fistulotomy, the laying opening technique, fistulectomy, ligation of intersphincteric fistulous tract. Then we use seton for the treatment of Fistula-In-Ano. Another option, surgical option, is advancement flap. Then we use biological agents like fibrin glue for the treatment of Fistula-In-Ano, and also anal fistula plugs. They are used to treat these conditions. So one by one we see different options for this Fistula-In-Ano. Now, what is fistulotomy? Fistulotomy, that the fistulous tract must be laid open from its termination to its source, was a rule. Fistulotomy, or laying open, is the surest way of getting rid of the fistula, but by definition it involves division of all those structures lying between the external and internal opening. So it is therefore applied mainly to the intersphincteric fistulae and transsphincteric fistulae involving the less than 30% of the voluntary musculature, voluntary anal sphincter, but not anteriorly placed fistulae in women. However, even then it is not immune to post-operative defects in continence. So fistulotomy is just laying open the tract. Here you can see that this is external opening and this is internal opening. The probe is passed in this tract. It is coming out through the anal orifice, and then the tract is laid open. Here you can see that. the tract is laid open, then which is curated and heals by a second intention. So it is mainly applied to low variety intersphincteric and transsphincteric fistula, because all the structures, they are divided. If it is done for the high fistula-in-ano, what will happen? Incontinence. All the sphincter fibers, they will be cut. So this is important. This is fistula-ectomy surgical procedure. Now, risk of fistula-ectomy, as I told you, in high variety, again, if we do this, what will happen? There is a high risk of fecal incontinence, because sphincter is definitely, it comes in the pathway of high fistula-in-ano. So this will result in incontinence. So sphincter preserving techniques are preferred than laid open technique of fistula-ectomy. What is fistula-ectomy? Fistula-ectomy is basically, this technique involves coring out of the fistula. Usually we use diathermy, cautery, to core out the tract. It allows better definition of fistula anatomy than fistula-ectomy, especially the level at which the tract crosses the sphincters and the presence of secondary extensions. They are more defined by this fistula-ectomy technique. If the sphincteric component of the fistula is deemed low enough to allow safe fistula-ectomy, then this may proceed. We can proceed for this at the expense of longer healing time than conventional fistula-ectomy. If laying open is not advisable, then the sphincteric component can be managed by another method. So fistula-ectomy, coring out of the fistulous tract, we use diathermy for this purpose, because this required a meticulous technique. There should be no bleeding. If you want to define the fistulous tract, we use diathermy, and there should be a ruthless hemostasis by defining. We can define the primary tract, we can define the sphincters, and we also can find secondary fistula. Investigations, they help us. They tell us that this particular fistula is high variety, where the tract is going on, but on the patient, it is the surgeon who is important, because that is going to define the fistulous tract. Imaging only helps us. So expert surgeon is required to do these procedures. Another surgical option for the treatment of fistula-in-ano is ligation of intersphincteric fistulous tract. Lift. Ligation of intersphincteric fistula tract. That it was first described in 2006 for transsphincteric fistulae. Technique involves disconnection of the internal opening from the fistulous tract at the level of intersphincteric plane. Remember this. Disconnection of the internal opening from the fistulous tract at the level of intersphincteric plane, and then removal of the residual infected gland without dividing any part of the sphincter complex. This is ligation of intersphincteric fistulous tract. Now the tract is ligated after doing this and divided. Internal part is removed and the external part of the tract is curated out and drained. Success in terms of healing in cases of this procedure lift is about 45 to, you can say, 95% the cases. This is lift, ligation of intersphincteric fistulous tract. Here you can see this procedure of lift procedure. This is external opening. Then here you can see the internal aspect, the anal canal. Internal aspect, the anal canal, probe going inside, and you can see here. So this is the internal, where it is disconnected from the from the fistulous tract, this internal opening, but going into the sphincteric plane, and then the external part is curated and this is drained. This is lift procedure. Seton placement is a very commonly used method of treatment for high fistula-in-ano. We use this option. Setons have been used in a variety of ways in fistula surgery, and it is important for surgeons to be clear about what they are trying to achieve in a particular situation. So this is preferable for surgical option for high fistula-in-ano, where if you do fistulotomy, then there is a chance of incontinence. Setons are usually made from rubber slings, but we use some people use proline, and I use silk number 1 for this thread used for seton placement, and this is patient is more comfortable with silk, non-absorbable suture. There are 2 types of seton suture they are placed. One is draining or loose seton. This loose seton facilitates draining of the sepsis. It is left loose, and this allows fistula to heal by fibrosis. This induces fibrosis, and that leads to healing. This is used before advanced flap technique. When we use that means advanced flap technique is used when this seton, loose seton, you can say, is a failure of that technique. This is also used as a part of stage fistulotomy, this draining or loose seton. Now another type of seton suture is cutting seton. I personally commonly use this cutting seton. This slowly cheese wires through the sphincter muscle and allows fibrosis to take place behind as it gradually cuts through. Here I can show you this. This is seton, how this is placed. You can see a thread. Here you can see these are the plastic slings which are used, but I use silk number 1 as a seton. Here you can see the tract, and this thread is passed. This anus, this is seton from the external opening. Then cutting seton is gradually tightened. My routine is usually after 4 or 5 weeks. We change this seton and also narrow it, thus cutting the sphincter sequentially bit by bit, and then tract fibrosis occurs behind as this descends downwards. This fistula, this seton descends downwards. Another technique, advancement flap. Advancement flap technique aims to preserve both anatomy and function. What is the principle of this option? Prior elimination of the acute sepsis and secondary tracts. So what is required? If we use this option, we have to eliminate acute sepsis. There should be no acute sepsis in fistulous tract, and we should also have treated or excluded the secondary tracts with ideally a direct tract from the internal to external. So this will be helpful, this advanced flap, when there are no secondary tracts and the tract is direct one from the internal to external opening. Principle again that we have to do a coring out of entire tract in this technique. Closure of the communication with the anal lumen with an adequately vascularized flap consisting of mucosa and internal sphincter, which is sutured without tension to the anoderm, well away from the site of the excised internal opening. I show you this in the next slide, this technique. Here you can see that this is the flap which is formed. This is the internal opening. Once the tract is cored out, Here you can see this, the tract is cored out up to the internal opening, and then this flap is sutured lower down to the anoderm. Here you can see. So this is the advancement flap technique which is used for the treatment of Fistula-In-Ano. Again, this is for complex fistula, high Fistula-In-Ano. Another technique option for treatment of Fistula-In-Ano is anal fistula plugs. The anal fistula plug is a minimally invasive and sphincter preserving alternative to traditional fistula surgery. The plug is conical device, and this is placed by drawing it through the fistulous tract and suturing it in the place. The plug, once implanted, this unincorporates naturally over time into the human tissue. Human cells and tissue, they grow into the plug, thus facilitating the closure of fistula. So here you can see this is the plugs. These are plugs, anal fistula plugs. These you can see the placement. Here the wire is passed. You can see this is the wire which is passed, and this is again attached here with this wire, and then when it is pulled, and here you can see flaps, mucosal flap, they are raised, and this plug is sutured in beneath the mucosa and submucosa. As you can see that this is the plug including the fistulous tract. And here the mucosa and submucosa, they are sutured over the plug. So this is the fistula plugs. This is another technique which is used for the biological agents. The functional consequences of fistulotomy and the poor eradication rates of sphincter preserving techniques have led to a search for the agents that essentially plug and seal the tract and allow ingrowth of healthy tissue to replace it. Success must depend on the biomaterial itself and the environment into which it is placed. The poor long-term results of fibrin glue. One biological agent which is used for the treatment is fibrin glue. The fibrin glue, probably there's a poor long-term results when we use fibrin glue from its relatively rapid resorption and thus inadequate time for the host tissue incorporation. Another biological agent which is used is porcine small intestinal submucosa. Cross-linked porcine dermal collagen have recently been studied, but only short-term outcomes are known. So research into biological agents must continue. Still, they are not very popular, not being used for the treatment of, commonly used for the treatment of Fistula-In-Ano. Now another option, especially in those cases which are complex fistulas, which are secondary fistula having underlying diseases. In those cases, what is the treatment? Obviously, in cases of secondary Fistula-In-Ano, we must treat the underlying disease. So in how the underlying disease is diagnosed. So when we are suspecting probably this fistula is secondary fistula, we have to take the biopsy, and that histology will confirm the underlying disease, the diagnosis of underlying disease. So in those cases of secondary fistula, when there is some underlying disease which is causative, we have to treat that disease. Our primary aim is to treat that disease. Now another option in very difficult fistulas, in complex fistulas, high fistula especially, is sometimes we have to divert the fecal matter. So that means stoma formation, left iliac fossa, colostomy, sigmoid colostomy. In very difficult situation, we can opt for this, for stoma formation, for the treatment of complex, high, difficult Fistula-In-Ano in which there are a number of treatment option failures. So you must remember, stoma formation, diversion colostomy is also done in cases of fistula-in-ano and complex varieties of fistula in which there is a treatment failure number of times. So this was all about fistula-in-ano. Now, if you have any question, you can ask me in your WhatsApp group and I'll respond to those questions. And then thank you very much. I will give you the assignment to respond for this lecture.